Hi guys, we are from Group G. Today we will be presenting about obstructive sleep apnea. Let's start with the definition. Apnea is the cessation of breathing for at least 10 seconds, or it means there is no breathing at all. While obstructive sleep apnea means there is collapse of the upper airway resulting in cessation of airflow during sleep. Let's move on to the etiology and risk factors of obstructive sleep apnea. It can be divided into structural and non-structural. Structural factors will mostly cause obstruction and can be at the level of nasal and nasopharynx, at the level of oral cavity and oropharynx, in which at this level, adenotonsillar hypertrophy is the most common cause in children, and lastly at the level of larynx and laryngopharynx. For non-structural risk factor, it can be obesity, male gender, age more than 40 years old, and others as well.
So next we'll talk about the pathophysiology of obstructive sleep apnea. So I'll talk about the fat deposition at the neck area and also what happened to the laryngeal muscle during nighttime. So fat deposition in the neck area is that if you are male, the fat tends to deposit at the neck area. So this fat will exert extra pressure on the airway, causes the airway to become narrower. Second, when the laryngeal muscle is during sleeping, especially during supine position, the laryngeal muscle is sleep also becomes flabby, less stiff, so the airway will further narrow down. So these two factors will causes the airway to be obstructed totally during sleep time. So what happens is that next, the lungs will try to get more oxygen in, the diaphragm will contract, increase in volume and decrease in pressure, try to get more oxygen in, but however, since airway is obstructed, no oxygen will be sucked in. So during this time, what lung will do is it will send a signal to the brain, ask the brain, hey brain, wake up, and then the brain will send the signal to the laryngeal muscle, ask the laryngeal muscle to wake up, to contract and become stiff again. When the laryngeal muscle becomes stiff, the airway opens up and more oxygen will get into the lungs. Now everything is okay, so the lungs will not send any signal to the brain anymore. Brain won't send any signal to the laryngeal muscle anymore. So laryngeal muscle will become flabby again, airway obstructed again, and the whole cycle recycle again. So that's why patients with with obstructive sleep apnea can't properly sleep well during the night.
Let's move on towards the history taking for obstructive sleep apnea. In history taking, it can be divided into three segments. It can be in form of daytime, where we see the pattern of the patient outside of sleep, during sleep, and also other relevant history, which is important in diagnosing obstructive sleep apnea. For physical examination, we have 5 different parts for the physical examination. They are BMI, collar size, Malus maneuver, systemic examinations, and also head and neck examination. For investigations, there can be 2 forms of investigations which can be done. Firstly will be cephalometric radiographs, where we search for craniofacial anomalies and tongue-based obstruction, and also polysomnography, where it is a collection of investigations intended to observe for obstructive sleep apnea.
So for the management of OSA, we divided into non-surgical and surgical. So basically for non-surgical, it's reduce the risk factor for you to get OSA. For example, weight reduction causes fat deposition, so you reduce weight, so it will not obstruct the airway. And then avoidance of alcohol, sedative and smoking, and it will make your laryngeal muscle to relax. And others is like CPAP, which actually build up the positive pressure, prevent your airway from collapse. Surgical is basically reduced to remove any tissue that obstruct your airway, for example, tonsil or adenoid surgery, nasal surgery, septoplasty. That's all.